Hi and welcome back to another video of Medic Notes. This video will be on ovarian cancer. It is the second most common gynecological malignancy after endometrial cancer. And if it is detected in early stages, ovarian cancer has an excellent prognosis. It is quite common where 1 in 70 women are at risk for ovarian cancer, and majority presented with symptoms at an advanced age or late stage of the cancer. It is mostly seen in older age and rare in young women, and it is associated with strong genetic factors. More women actually die from ovarian cancer compared to cancer of the cervix or cancer of the uterus. This is the classification for malignant ovarian tumor. It can be classified into primary or secondary, which is the metastatic tumor originating from other sites of cancer. For primary tumor, it can be divided into epithelial tumor, which is the most common, consists around 80% of the cases, and it can also be germ cell or sex cord stroma tumors, which are less common. In epithelial tumors, it can be further divided into subtypes like serous, mucinous, endometrioid, clear cell, and undifferentiated tumor. For germ cell, it can be further divided into dysgerminoma, yolk sac tumor, teratoma, choriocarcinoma, or mixed tumor. Whereas for sex cord stroma tumor, there are 3 types, which are the granulosa cell tumor, Sertoli Leydig tumor, and gynandroblastoma tumor. For metastatic tumor, it can be a secondary tumor originating from the colon, stomach, or breast cancer. So majority of the primary tumor are epithelial type, and the remainder are germ cell or sex cord stroma tumor type. These are the risk factors which put a woman at a higher risk of having ovarian cancer. So especially those who had no children, nulliparous or low parity, early menarche before 13 years old, late menopause, late age of first birth of baby, endometriosis, cigarette smoking, any family history of BRCA1 or 2 mutations, or family history of breast cancer, and also HNPCC, which is the hereditary non-polyposis colonic carcinoma. The symptoms that they may present with, for early stage, there may be no symptoms or non-specific symptoms, and in later stage, the most common symptoms are pelvic and abdominal pain, which are persistent in nature, increase in abdominal size, abdominal swelling or persistent bloating, and also early satiety, where they feel full very fast, and also loss of weight. Compressive symptoms and change in bowel habit, urinary symptoms like urinary retention or frequency, backache, shortness of breath, irregular bleeding like abnormal menstrual periods or postmenopausal bleeding, and constitutional symptoms like fatigue, loss of weight, or loss of appetite. These are some of the symptoms of ovarian cancer. On physical examination, first we have to do abdominal and pelvic examination. So the characteristic of ovarian mass are listed over here. So it is important to differentiate. If there is a mass, we have to differentiate whether it is ovarian origin or uterus origin. So the signs that suggest for ovarian mass would be the site at either right iliac fossa or left iliac fossa. The consistency will be cystic or firm. Mobility, it is mobile up and down and also side to side. We can get below the margin of the mass, and during bimanual examination, the cervix does not move from the fingertip. If it moves, it's more suggestive towards uterine mass. We can also do neck and groin examination to look for enlarged lymph nodes. Bimanual examination, stated just now, vaginal and rectal examination to feel for any fixed, hard, or irregular mass, and also chest examination to check for signs of pleural effusion, which could occur in an ovarian cancer. So this is the comparison between uterine mass and ovarian mass. The mobility for ovarian mass, it can move side to side and up and down, whereas the uterine mass can only move from side to side. It is not mobile up and down. For consistency, ovarian mass is usually cystic, And the location, like I said just now, ovarian mass is either at right iliac fossa or left iliac fossa. Can get below the mass, whereas for uterine mass, we cannot get below the mass. It can also be differentiated through bimanual examination, where the cervix does not move from the vaginal finger in ovarian mass. The investigations include blood investigation like full blood count, which is to assess for the hemoglobin level, the white blood cell count, and platelet level, to exclude any anemia, infection, or bleeding disorders. Liver function test to exclude metastasis to the liver. Renal profile to assess the kidney function, because if there is a large pelvic mass, it may compress the ureter, which will cause hydronephrosis and subsequent kidney damage. Serum tumor markers, especially CA125, is increased in 80% of the epithelial ovarian cancer, especially in serous type. And group Ceph and whole can be done as a preoperative preparation, and also for blood transfusion in case of massive blood loss during operation. So the serum tumor markers, besides the CA125, there are also other tumor markers suggesting for different ovarian tumors, such as beta-HCG, if high, suggesting for dysgerminoma or choriocarcinoma, alpha-fetoprotein, suggesting for yolk sac tumors or teratoma, and many other blood tumor markers, serum tumor markers. Urine investigation include urine pregnancy test to exclude pregnancy. And for imaging investigations, we can do ultrasound of the abdomen and pelvic to assess the origin of the mass, see the size and the appearance. And ultrasound is also useful to look for features suggestive of malignancy. For example, some of the signs of malignant ovarian mass would be bilateral mass, multilocular, thick irregular capsule and thick septa, solid area with mixed echogenicity, papillary projection, and also ascites. So to detect for metastasis, we can do chest x-ray, CT thorax, abdomen and pelvic, MRI scan, barium enema or colonoscopy, and also intravenous pyelogram. So chest x-ray is to detect for pleural effusion or pulmonary metastasis, and also useful for staging. Barium enema or colonoscopy to differentiate between ovarian CA and colon CA, and also to assess whether the bowel is involved or not. Intravenous pyelogram to detect tumor invasion into the urinary tract. So the most promising diagnostic investigation approach would be a combination of the tumor marker CA125 plus ultrasound. The staging of ovarian cancer is based on this FIGO staging, where there are 4 stages. So stage 1, the growth is limited to the ovaries. Can be divided into 1A, 1B, and 1C. 1A, the tumor is limited to 1 ovary, capsule intact, no ascites. 1B, it is limited to both ovaries, capsule intact, no ascites. 1C, it can be either 1A or 1B, but the tumor on surface of ovary with ruptured capsule, or with ascites positive for tumor cells. Stage 2 is the tumor is confined to the pelvis. So it can also be divided into A, B, and C. 2A is there's extension of mets to the uterus or fallopian tubes. 2B, extension to other pelvic organs. And 2C, it can be 2A or 2B, but tumor on surface of ovary or with capsule ruptured or with ascites positive for tumor cells. It is quite similar to the 1C. For stage 3, the tumor is limited to abdominal peritoneum, or there is positive retroperitoneal or inguinal lymph nodes. Can be divided into ABC as well. And stage 4 is when there is distant metastasis, where there are positive cytology on pleural effusion or liver parenchyma. So this is for the FIGO staging. For treatment of ovarian cancer, the mainstay of treatment is surgery. And we can do staging by laparotomy staging, and surgery like TAPSO, which is total abdominal hysterectomy, and bilateral salpingo oophorectomy, plus infracolic augmentectomy, plus peritoneal cytology, plus lymph node dissection. This is the mainstay of treatment. So first, for surgery can be done for diagnosis, staging, and also treatment. The primary surgery for stage 1A and 1B, where the tumor are confined to the ovaries with capsule intact and no ascites. For stage 1, we can do conservative and fertility-sparing surgery for young women with early stage. If completed family already in stage 1, can offer Tapso, infracolic omentectomy, peritoneal cytology, and lymph node dissection. So chemotherapy can be given if the patient is unfit or unwilling to have surgery, or the staging is 1C and above. Can give adjuvant chemotherapy, which is a combination of carboplastin and paclitaxel. Can also do neoadjuvant chemotherapy if the tumor size is very big, so reduce the size before operation. Radiotherapy, not effective in ovarian CA. It is only for palliative care for advanced stage. However, it is effective for this geminoma, which is a radiosensitive tumor. Palliative treatment for those who are not suitable for surgery, not fit for any intervention, and also to relieve the symptoms and control the disease. We can also refer the patient to dietitian for high protein diet and supplements to build up their body so they can tolerate the side effect of chemotherapy. So this is the summary of the surgeries that can be done. For stage 1A, unilateral salpingo oophorectomy. Stage 1B, Tapso plus omentectomy. Stage 1C and above, Tapso, omentectomy, lymph node clearance, and chemotherapy. For follow-up, it can be done every 3 to 4 months for 2 years, and then 6 monthly for 5 years, then annually follow-up. And the follow-up, we monitor using clinical examination plus minus the measurement of CA125 tumor marker. So the follow-up schedule will be different for different age groups and also postmenopausal and premenopausal women. So that's all for this video. Thank you.